I'm going
Recording.
I'm going to make a recording of this meeting. So thank you so much for being with us, and the floor is yours. Thank you so much.
Thank you. Well, thank you all for joining us this evening. I'm very happy to present to you on this technique, on the revised Meek technique. I know it's very difficult to do proper or to do burn care in Africa, on the continent of Africa. And I know that Meek might be one of the solutions, and this is why one of the reasons why my former colleagues from Rotterdam they brought it to the continent with Interplast. And Dr. Kees van der Vlies is a colleague of mine, former colleague who works in Rotterdam. And I also spoke to Dr. Jenda Hop, and they discussed with me that maybe it would be a good idea to present on this topic with you tonight. So I worked at the burns unit in Beverwijk from when I was a student in '98, and I started working as a burns physician in that unit in 2001. And I was trained by Dr. Krijs, who introduced this Meek technique. And because I started working with it rather early, like in the 90s already, I have seen all the mistakes made, and I hope to share with you how you can overcome some mistakes that are sometimes happening, because there is some kind of learning curve. But prior to going into the technique, I will also tell a little bit about the advantages of Meek for you to understand why it would be a procedure you want to choose sometimes over the mesh procedure. So I will start sharing my screen. Here we go. So this is on Meek, why and how. Currently, I'm the medical advisor to Jamaica because my husband, he got a job on the other side of the country, so I wasn't able to work at the burns unit anymore. And also my children, I have 4 children, and they were hitting adolescence, so it was nice to be home as a mom. So my main job right now is being a mom of 4 children, and also I do still some medical advising to Jamaica. So why would you use the Meek micrograph technique? It's because it has a true expansion ratio, and this helps with for a low donor site morbidity. So this is what the principle is. You harvest a very thin split thickness graft that you place on a cork with the dermal side down. Then this cork with the skin on top of it is run through a machine twice to cut the split thickness graft in little squares of 3 by 3 millimeters. This is then transferred to a pre-folded gauze, and the cork on which the skin is placed is then removed. So now we are looking at a pre-folded gauze with all the skin islands now facing dermal side facing up. And because this gauze is folded, the width of the pleat depends. Depending on the width of the pleat, you can expand the gauze further or less far. So if this is very small, then you cannot extend the gauze as big as this. So the whole enlargement ratio is in the gauze. The whole process for each expansion ratio is the same, but the length of the pleat helps you get your expansion ratio. So after expanding the gauze, you will then place it on the wound with the dermis on the wound bed. So this is what it looks like. Here you have your skin on your pre-folded gauze, and then after unfolding that gauze, you can place that on your wound bed. I will dive into this technique more in detail later, but first we will go into why the expansion ratio in the Meek is exact, whereas with a mesh graft, it is not a true expansion ratio. Dr. Peters from Belgium, he showed that when you harvest a piece of skin, for example, right here, a graft of 80 square centimeters, if you were to mesh that 1 to 3, you would expect that you would get a surface area that you would be able to cover with that 80 square centimeters of 240. And this goes the same for if you have a donor size or a split thickness graft of 100 square centimeters, then you would expect that you would be able to cover 300 square centimeters. However, if they measure the expansion, the expanded skin when using a mesh 1 to 3, you see all these little dots. So they harvested 80 square centimeters, they meshed it 1 to 3, and this is what they measured, calculated or measured. And if you see all these little dots, this is all grafts meshed 1 to 3. But if you calculate it, you see that it's only 1 to 1.5. So the expansion ratio with a mesh graft is not a true expansion ratio. A 1 to 3 equals about 1 to 1.5. Whereas with the Meek technique, if you harvest this much skin right here, you place that on the pre-folded gauze and then you unfold the gauze. This is the area that you would be able to graft with the Meek 1 to 6. And this would be the area that you would be able to graft this whole piece with the Meek 1 to 9. And this is really 9 times this area. So with the Meek, you have a true expansion ratio. And the same goes for the Meek 1 to 4 and the Meek 1 to 2. And we also have a Meek 1 to 3. So we need a smaller donor site when using the Meek technique when compared to the mesh graft technique. And there is another slide. This is the donor site that you need to cover a wound of 100 square centimeters when using a certain expansion ratio. And again, I like to pay attention to the mesh and Meek 1 to 3. So if you were to need to cover 100 square centimeters, then with the Meek technique, you need to harvest 33 square centimeters to cover that 100 square centimeters when using a Meek 1 to 3. When using a mesh 1 to 3, you would need to harvest almost 70 square centimeters to cover that same wound. And that same goes for all the different expansion ratios. So as you can tell, the purple line, you need a lot larger piece of skin to cover that same area when using a mesh compared to a Meek in the magenta line. And this is another example of this. This has all been published, all this work. So if you were to harvest this black area donor site and then Meek that 1 to 3, you would be able to cover half the side of the trunk. Whereas with a mesh 1 to 3 with that same donor site, you would only be able to cover this side of the trunk. And if you would like to cover that whole side of the trunk with a mesh 1 to 3, you would need to harvest everything inside this orange line, which means also the medial side of the leg. And also, so we need less skin to cover the same wound, or with the same donor side, we can cover a lot more of the wound bed. And also the thickness of the grafts, you can harvest as thin as 8/1000 of an inch or 0.2 millimeters, because the micrografts are very easy to handle and you have less problems with shear forces, which I will show in the next few slides. There is this Meek with all the islands on top of the gauze that you can very easily apply even in the axilla. It is not a problem. Whereas if you use the mesh graft with a high expansion ratio, you tend to harvest the graft a little bit thicker to prevent the skin from breaking. And if you see it on the wound bed, it looks rather fragile and it's very prone from sliding and moving around with shear forces. And if you compare these two, this one and this one, you see that this is less fragile. The Meek 1 to 4 is this, and this is a mesh 1 to 4. These gauzes do not slide back and forth, whereas this skin graft is easy to slide back and forth. So in total, we need smaller donor sites and we can harvest very thin. So you have a lot less donor site mobility, faster healing of the donor site, and you need less skin. And also because of the faster healing in the donor site, you can reharvest that same donor site earlier. Is there any questions on this first part of the lecture? If not, then I will continue. So now we will start talking about how you perform the Meek, some pre-operative thoughts, we will dive into the technique with the post-operative tips. And in this part of the lecture, I will also talk about how to overcome the most frequent pitfalls. And then we will talk a little bit about post-operative treatment as well. So it's very important, obviously, with every procedure that you plan your procedure ahead of time. And what are things that you need to think about when using a Meek? Obviously, what post-burn day and what area do you want to excise and graft? And then which enlargement ratio am I going to use for you to be able to choose your donor site? And this last, to choose your donor site, is important because the ward needs to know what donor site you will choose, because they are not allowed to use any oil, cream, or lotion on their donor site on the day of surgery, because this will impede the working of the glue. So the donor site cannot be creamed or with body lotion or any oil. And then this is an example of how to calculate the donor site and also how many gauzes you need. We see this patient with a large burn on his back, and we have very little donor site, and we have decided to use the Meek 1-6 and 1-9. So this, for this area, is about 13% of the back of the patient. So we have a special chart in which you can calculate how many gauzes you need to perform your procedure. So for example, if we would choose to use a Meek 1-9, we go to the chart of the expansion ratio Meek 1-9. Then we need to find out the weight of our patients. So in this example, the patient's weight is 80 kilograms. That's right here. And our patient is 1.75 meter. So his 175 is his length. Then in this chart, this tells us how much gauzes we need to cover 1% of the burn. So if our patient were smaller, if he were like, let's say 150, and he was only 60 kilograms, then we need a little bit less skin. So with this calculation, you know how many gauzes of this expansion ratio you need to harvest. And in this case, 1% is about 1.1 gauze. So we need a little bit over 1 gauze to cover 1%. So this is why we choose, when using a Meek 1-9, to choose 14 gauzes, because 13 wouldn't be enough. We need 14 gauzes to cover that 13%. If we were to use the expansion ratio of 1-4, because maybe you have a lot of donor site for that same patient with the 80 kilograms being 175, you would need 2.5 gauzes per percent. So that would mean 13 times 2.5 gauzes, which is a lot more, which is logic, because we are using an expansion ratio of 1-4. So this is a chart that you can use prior to your surgery to calculate the number of gauzes that you need to go into your procedure. And with this patient, we used a Meek 1-9 as well as a Meek 1-6. And we harvested a lot of the donor site right here. This donor site, you can see, is a very thin area of non-burned skin. And this is the area where the leather belt of this patient was. So his trunk was burned and also a lot of his legs, but because of the leather belt he was wearing, we had some donor site right here, and we were able to harvest that right here. And this is not 15, it should be 51. I apologize. And this is what the skin looks like about 2 years post-burn. So when you decide on your procedure, this is important for you to know what donor site am I going to use, and also how many gauzes am I going to need. And then when you do the procedure, we always think about wound bed preparation. This is the same as with any other procedure. So I will probably tell you stuff that you already know, but it's just to get that whole picture of the procedure going. So we need a proper wound bed preparation, and then we will dive into the Meek technique itself. So the grafts can be placed on vital dermis, fat or muscle, also on dermal matrices, either synthetic, bovine or porcine. However, it is not wise to place any Meek grafts on hypergranulation tissue, because the grafts usually will not have a good graft take on that type of tissue. So good wound bed preparation is important, but this is not new to you. And this is just a few examples. If you were to do a primary excision and you would do an avulsion down to fascia, so you have an en bloc excision down to the fascia of the muscle, that would be a reliable wound bed on post-burn day 3, and that this would be a wound that you would be able to use the Meek on. If you do a primary excision, but the tangential, early tangential excision, that would not be a very reliable wound bed to graft on that same procedure. In that case, I would recommend to wait for 5 to 7 days more longer to find out if the wound bed is reliable prior to using your precious autolog skin graft to perform your grafting.
And delivery finish or the same thing.
In this right here, you see that there was some grafting done, but the wound bed dried out.
It's not right.
And so
Yes.
is there a question? Excuse me, is there a question? Oh, if there's no question, I will proceed. I'm sorry. So with the secondary excision, the revascularization of the wound bed is complete, and then when you do a tangential excision, then the wound bed is a lot more reliable than a tangential excision in the primary stage. And in those cases, you can graft with the Meek no problem. And as said before, regrafting old wounds or grafting on hypergranulation tissue, the Meek will not take very well on this type of tissue. So we would remove that. Obviously, we will not remove that on tendons and bones, because we need that granulation tissue for covering of those tendons and bones. But if there is no tendons and bones underneath, then we would recommend to remove all that hypergranulation tissue down to the fibrinous tissue underneath. And that's the tissue that looks a little bit like this, the kind of peachy color wound bed. And then we will go on to how to prepare those micrografts. As said before, the donor site, it's very important to not use any oil body lotion on the donor side, also when harvesting the donor site. I know a lot of doctors are used to using some kind of oil when harvesting the split thickness graft. When using a Meek technique, I would not recommend this, because the glue will not work if the skin is oily. So what we will usually do is just moisten the donor site either with saline or with sterile water for it to slide over the donor site. And in some cases, I know of hospitals that we use adrenaline solutions to also diminish the blood loss from the donor site. So they would wipe that donor site with some adrenaline solution. It is wise to use a dermatome with a not wide head, but with a small head, because the corks on which you are going to place the skin is 42 millimeters. So our company has its own dermatome for this procedure. It's the D42. However, you can also use other dermatomes, but then use the guards to narrow down that split thickness graft, because it saves you a lot of time in preparing the Meek graft. Because that split thickness graft that you just harvested needs to be placed on a cork with the dermal side down, epidermal side up. And it needs to be cut to size. So if your split thickness graft that you took is the exact width of your cork, there's a lot of less cutting to be done, which speeds up your procedure tremendously. So what we usually recommend is to place your graft with the dermal side up on a cutting block. You can also just place it on your drapes. This is something that I used to do, just place them on the sterile drapes and then dermal side up, and then place those corks on top, and then you need to cut the skin for that to transfer it to the cork. And it's important to cut it to the same size, because when the skin is run through the machine will not cut the trims off. And if you have little pieces left over skin, as depicted in this figure here, you see you can use little pieces of skin to cover that whole cork. And as shown in this picture, it's to the edge, but not over the edge of this little cork. And it's important to remove the folds from the skin. Like here's a little fold still. You need to flatten that out for the skin to be properly cut. And then the skin is placed in a cutting block. So 2 corks are placed in the cutting block. You wetten the skin. You need to really wet this thoroughly. You need to clean the lid with just saline water, wetten it with saline water, and then close the lid. And you can close it by these little screws that you need to push and turn. And then it is run through this machine right here. And it's placed on these two, reels, and then this machine, you run this little handle right here to run it through the machine. And in this machine there is 13 blades that cut the skin. So under this bridge there is 13 blades, and to keep this blades in place and to cut the skin properly, the little golden knobs that are right here on top of the bridge need to be tightened securely. So you run it through the machine once, and then you open the lid while using this comb, and you lift it and then you turn it, and now the skin is cut into little strips. But we need to go to little squares. So what you do is you pick up these cutting blocks and you turn them 90 degrees, as shown in this picture. And then you run these cutting blocks through the machine in the same manner. And then the skin is cut into little squares, as shown in this picture. To be sure that the skin is cut in little islands, you can bend your cork to see the lines of the cuts. In this, you see the strips, and if I were to bend the cork in the other direction, you would see those same lines. Sometimes it's just kind of difficult to tell if you have squares. In this picture, it's rather easy to see, but if you are not sure of there is many corks as shown in this, it is wise to check if the cuts are done properly. Then this skin, the epidermal side, is sprayed with the glue, and the glue needs to dry for 5 to 7 minutes, or for the glue to turn from shiny to dull. So in short, again, we are placing the skin with the dermal side down on the cork. It is run through the machine. We are looking at the epidermal side right now, and then it is placed on a big table sprayed with the glue, and then we wait for it to turn from shiny to dull, usually 5 to 7 minutes. And then you pick up your little cork with all these skin islands, and then you place them on those pre-folded gauzes. And the pre-folded gauzes have an aluminum backing, as shown right here, to keep those folds in place. And it has a nylon structure as the gauze. You gently remove that cork to see if all the skin islands are transferring from the cork to the gauze. So I would start with the first corked, and then watch carefully if all the skin is transferring. If not, then place that cork back on the gauze and wait longer for the transfer to be complete. So start with one, check if those islands are transferring, and if they are, then you can continue with the other corks. But if the first one did not stick properly yet, you need to wait a little bit longer for the glue to do its work. And then after removal of those corks, you are looking at the dermal side of your skin again, and this is what it looks like. And it's important to notice that the skin is only in the center of that gauze. These rims right here, we need to make those folds in a machine. But in those areas, there is no skin. And after the skin is transferred to the gauze, you can unfold the gauze by pulling on the zigzag side first, and then pull the other side. And right here, you see that gauze with all the islands now in the expanded version. And right here, it's placed on the wound bed. So right here in this picture, you still have the aluminum backing at the back of the nylon. You remove that aluminum backing, and then you can staple this to the wound bed. It takes about 5 to 7 days for the skin to grow in. So you need to staple this to the wound bed to prevent it from shifting. And it is very important to flatten out that gauze to have your little skin islands really touch your wound bed. So apply the gauze without folds onto the wound bed to have proper contact between the skin islands and the wound bed for the skin islands to grow in. And as said in the previous slide, there is no skin around, so you either cut those rims off, and it's in this picture you see it being cut without the aluminum backing, but if you choose to cut those rims, it's easier to cut those rims when the aluminum backing is still on, because then the gauze is less floppy. It's easier to do that cutting. If you decide not to cut those rims, which I know of a lot of hospitals that don't, then make sure that you fold those rims back as shown in the middle picture right here. You have to fold those back to prevent this from happening. If you do not align the skin, but you are only aligning the gauzes, then you may end up with these kind of landing strips in those Meek fields. So you really want to align the skin instead of aligning the gauze. So fold those rims back, make sure that you place skin islands right here to prevent those landing strips from happening. And as said before, it's very easy to apply the micrographs. To flatten out on the wound bed, there's another suggestion that I would like to make. I know of a lot of hospitals that would run this gauze through a saline. So prior to applying it to the wound bed, they would wetten the gauze with saline, and then those folds will disappear, and it is easier to apply without the folds. So I will now go through some troubleshooting for you to understand what might happen. So sometimes when the first time the cutting block is running through that machine, the screws are not pressed down completely, and then you hear a loud squeaking noise. And that is because then these screws are hitting the X of the blade X. So if you hear a funny voice, always make sure that these screws are pressed down completely. Another troubleshooting thing is that sometimes it seems that the skin is not cut properly, and that might be due to the fact that there is not enough air pressure to the machine, and that causes the blades not turning properly. And the other last reason would be that we have this blade axis right here, and then we need to place the bridge on top of it. And I shown before that there is little golden knobs right here, and these need to be tightened very well for the bridge not to move up and down under the bridge. You can understand that if the blades are going up and down in this machine, then the cutting will not be done properly. So always make sure to tighten those. And I also hear that people have problems of skin sticking to the lid. And it's to prevent that from happening, it's very important to apply copious saline solution on top of the skin. Also to clean the lid of the skin when you start the procedure, and use the wedge when opening the lid. And I have seen hospitals see this problem, and this is because they are moving this wedge back and forth like this, but the wedge is only to be used pressing down instead of moving back and forth. So these are just a few little hints that you can master to prevent these pitfalls from happening. And since this is recorded, I'm sure they would be happy to share this recording with you, so you can look back at this and kind of memorize or hear this once again to find out what tips and tricks there are to do a Meek procedure. And also, I'm very happy to help you and to assist you if there is any problem arising, and you can very easily get in touch with me via the company. And there is another thing that is just a suggestion out of the clinic. Sometimes the transfer from the skin, from the cork to the gauze is not complete. So sometimes for some reason, there's not enough glue on this area. So there is proper transfer right here, but there's a whole area where there is no transfer. So what you can do is just cut off this piece of cork, discharge that piece, and respray. So spray again new glue, wait again for 5 to 7 minutes, and then apply again. Remove that piece of cork, and then you see complete transfer. Obviously, this can only be done when there is like a complete area not transferred properly, like for example, a third or a quart. Then it's worth a while to do this. If the transfer is not done completely, but in a scattered manner, so there is here and there a little skin islet not transferred, then this is not an option. And now a little bit on post-operative treatment. Well, there is many ways that lead to Rome, and I think it's all about a preference of the team, but also availability of products in your unit. And the only thing that I want to address is that the treatment needs to be avoiding desiccation of the wound bed, but also avoiding too wet wound bed. So we are looking for a moist wound bed. And I would say that you could use any type of product that is in your unit that does this for you. So avoid too much fluid and avoid desiccation. And there is multiple options, either with foams or ring outs or just iodine or Vaseline gauzes. And in some hospitals, they use negative pressure therapy, but that is like something that we usually do not use very often, the negative pressure therapy. I will come with some photos after a few slides. So as said before, the Meek islands grow in, and that takes about 5 to 7 days. So the removal of that white Meek gauze can be done after 5 to 7 days, but you can leave them also on for a longer period of times, for at least up to 14 days. The Meek gauze does not grow in to the wound bed. However, it can be tied to the wound bed. So it's wise to have like about 12 to 24 hours cream treatment on top of the gauze prior to removal of the gauze. So when you are planning on removing those micrograft gauzes, it is wise to apply some kind of cream-based treatment on the gauzes at least 12 hours prior to removal. And this is just pictures of examples. So this is on the day of surgery, and this is about 5 days after surgery, where the wound bed is kept kind of moist. The wound is already starting to heal. These gauzes are attached to the wound bed. We cannot slide these back and forth, so it's not a wet wound conditions, but moist wound conditions. And if the wounds, the gauzes cannot be slided back and forth after 5 to 7 days, then I suggest that you leave these gauzes on for longer, or at least you are able to do without harm. However, if the wound looks a little bit more like this, it's kind of sloppy, and these gauzes kind of smell a little bit, and you see some discoloration, then I feel like you may want to remove these gauzes, because you are not sure if to keep those gauzes on any longer is a good idea, because there might be some microbe problem going on. If the wound is smelling and kind of wet and there is some discharge, you want to remove those gauzes to be able also to clean the wound better. And so after removal of the gauze, you see all these little islands being they grown into the wound, and they've detached from that gauze. So this is another example of which I would think you would want to remove those gauzes. These are easy to slide back and forth. There is some discharge underneath the gauze, and if you see that, then you want to remove that gauze after 5 days. So that first picture with those legs, then there is no discharge under your gauze. It is kind of adherent to the wound bed. The gauze cannot be slided back and forth. In those cases, you can keep your gauze on for longer than 5 to 7 days. However, if you look at a wound where there is some discharge underneath the gauze and it smells a little bit and you feel like, I'm not sure what's going on, you want to remove this, and then to be able to see what is going on underneath your gauze, to see if your Meek islands had a good take, and then you can start doing your post-operative treatment to protect those islands and to help them to grow out, and to also protect the wound that's in between those little islands. And again, we are looking for moist wound conditions because we do not want the wound to desiccate between those islands. We want those islands to start to grow out. So in this case, we have a lady with a wound on her back that has been tangentially excised, and we performed the Meek procedure. We used the Meek 1 to 4 in this case, and then this is what the graft take looked like after about 7 days. And to protect those little skin islands again, so this is after removal of the gauze. You can use any type of treatment that is available to your unit and what is the preference of your team. And we always say, just treat those Meek islands the same as you would treat a mesh graft that is just grown in. And that could be either foam or topical antiseptics, the sandwich graft technique with either allografts or xenografts, matrix type of dressings, or in some hospitals, for example, in the US, they use cultured skin on top. This is a foam dressing. This is a silver containing foam dressing that you would place on top of those Meek islands, and you can keep that into place for 3 to 7 days, and the Meek will grow out underneath. And this is just topical antiseptics. You could use ring outs as shown in this picture. Ring outs are really moist gauzes with antimicrobial fluids, and that can be any antimicrobial fluid like iodine, furosin, silver nitrate, Dakins, of acetic acid, PHMB, different kinds of treatments that are available to you that can be placed on the wound bed to prevent the wound from drying out. Another type of antiseptic dressings would be just ointments or creams that you would apply and then maybe place some non-adherent gauze on top and then cover it with, for example, King's cotton for the skin not to dry out. This is an example of the sandwich graft technique. If you look very closely, you see all these little skin islands right here. This patient had very few donor sites, so we would not be able to graft again, like to make more grafts in this. So this was a Meek 1 to 6, I think. And we were placing these homografts, allografts on top of this for the skin to grow out underneath these allografts. And these allografts would stay in place for 3 to 6 weeks. And then the skin will grow out and will push off this allografts. So that's like the Alexander graft is another way, another name for this sandwich graft technique. And I think we have come to the end of this session. So in short, why would you want to use the Meek technique? It would be because you harvest a lot less to cover the same wound, or you can harvest the same area but be able to graft a lot bigger wound. And also you can harvest very thin, so you have very low donor site morbidity. And it's very important to harvest very thin so you can reharvest that donor site very fast. Make sure to not use oil. We are using that pre-folded gauze that in which we align the skin. That is very easy to apply, and you leave the graft into place for 5 to 7 days or up to 14 days. And the post-operative treatment is according to the same as mesh graft in your unit. And I will stop sharing the screen. And I'm just wondering if there's any questions. And again, this is recorded. So if you feel I need to see this again, I'm sure that they would be happy to provide you with this recording to go over it again. And if you need to reach me, you can email me at Tempelman. I will put that in the chat for you to see for everyone. And you can just write that down. And you can always email me with questions. I'm very happy to be of assistance. I think in the chat you all can see my email address. If you do a procedure or you have a question concerning a patient in which you feel maybe I want to do a Meek, and the first question is coming in. So please get in touch with me, no problem. I see Mr. or Mrs. AZ is asking, how do you secure the gauzes on the patient? So we usually use staples. That's the easiest way. And I would start at one corner, staple one staple in that corner, and then stretch it out and then staple the other corner. So first do all the corners and then another staple in each middle section. That would be the easiest way. I know of hospitals that secure it with like a Echelon or whatever, like a real stitch. It takes a lot longer, and especially in the Meek technique, you need a lot of staples. So if you do have staples, please use staples. If not, you can also suture it. And I know of hospitals that just do a big pressure, what you call it, and a pressure dressing, to not use staples at all, but place those Meek without the staples, but then do not open the grafts until after 3 days. So that would be a reason. Do we need to wrap the patient with gauze dressings after apply the Meek dressing? So the gauze, so the Meek gauze itself is the treatment with which the skin is attached to the wound bed. However, if you leave it open to air, then your wound will dry out. So I would always suggest to place a secondary dressing on top of your Meek gauze. And that could be either just dry gauzes or a wring out of some kind of fluid. If you feel like your patient is rather clean, you could use just saline. Or if you feel there is more microbes going on, you can use either betadine or some kind of acetic acid wring outs, or you can also use Vaseline gauzes on top of your gauze. But please, you need to dress your Meek gauzes with a secondary dressing to prevent the wound from drying out. I hope this answers your question. Would you recommend use of technique across joints? Oh, that's a nice question. So would you recommend the use of the Meek technique over joints? Yes, we do. But I would recommend to use a smaller expansion ratio. So for the trunk, if you have very little skin, not a lot of skin, I would suggest to use Meek 1-6, maybe even a Meek 1-9. But on the arms, I would use a Meek 1-6 or a Meek 1-4, but at least a Meek 1-4 around the elbows. So if you are grafting an arm, you can go for a Meek 1-6, but around the elbow, I would go for a Meek 1-4 or maybe a Meek 1-3. Same goes for the knee, a Meek 1-4 or a Meek 1-3 around the knee or the ankles. And we do have a Meek 1-6, 1-2 or a Meek 1-3 that we use in the neck region. I know of a lot of doctors nowadays in the US are using Meek 1-2 for hands because they feel they need so much less skin, and they are using it also on smaller burns now because of the low donor site morbidity. So yes, you can use this across joints, no problem, but use a smaller enlargement ratio for better scar outcome in those areas. Why the name Meek? Oh, very nice question. So the first time that this technique with the little skin islands and the pre-folded gauzes came into the market was in the early 50s. So in 1954, I think, even prior to mesh grafts. And then this was done by Dr. Meek together with his colleague Wall. So Mr. Wall was the engineer and Mr. Meek is the doctor who invented this technique. And then in 63, Dr. Van der Put came with the meshcraft technique. And then the Meek was long forgotten because the meshcraft was a lot faster. And then in the 90s, when burn units were established, people with larger burns would survive. And then we needed a more effective way of skin enlargement. And then Professor Kreis, my mentor, he reintroduced that Meek technique and he used that same name. So this is why Meek. How expensive is the Meek machine and the corks and the consumables for low-income countries? That, I'm sorry, I would not be able to answer those questions to you personally, but if you send those questions to me in my email, I will have that transferred to my colleague who knows the distributors in the certain countries. And I know that we are working with Interplast also to get the products to the different countries in your region. but I'm afraid I don't know, because I'm only the medical advisor. I'm not in the commercial side of the business, I'm afraid. How do you handle early infection causes before first opening? So yeah, okay, so I like that question. So how do you handle early infected gauzes before first opening? So what we would usually do is, if you feel that there might be a problem, I would do a first check 24 hours after your first procedure. And if you see that there is some discharge underneath your gauze, I would cut your gauze and then remove that discharge and then replace the gauze. And it is, if you feel that there is a big problem, if you feel like there might be a big problem with microbes, I would suggest to first do wound bed preparation, get the microbe counts down before you start grafting. It's the same with the mesh graft, but and once you've got the microbes count down, then you can do your grafting. But if there is still a problem with your micrografts, then what you can do is clean your wound and also clean your gauzes. You can, we use antiseptic soaps even to clean the wound, but then you need to rinse that soap off with water. And also you can manually try to remove the discharge that piles up underneath your gauze. And it's important to always, I'm not sure if you have those resources. It is wise to do a culture to try to choose your secondary dressing according to culture. So if you know what bacteria is in your wound, then you may want to address that microbe with your dressings, using dressings that are against those certain microbes. I hope this kind of answers your question. Is there an electric version that automatically gets onto the corks? So there is no, it is there, so the question is there an electric version that automatically cuts the skin on the corks? Well, the machine that I've shown you today, that's the machine that is in use nowadays. So there is no electric one. So it is either air pressure from the wall using that motor that runs on air pressure, but we also have one that is manual. So if there is not enough air pressure from the wall in your unit, then there is also a manual one that turns the blades. So then you need two persons to run that machine, one who is running the wheel to get those blades turning, and the other one who is running the other wheel to get the cutting block underneath the blades. So that is two solutions. So either air pressure or manual, but not an electric version just yet. I'm sorry. Our dermatomes, they run on batteries. So the dermatomes are hose-free, very easy in use, even for the more difficult donor sites. And they're battery driven, and their batteries, as well as the motor, come out. They do not get sterilized. So the lifetime of that motor and the battery is very long because they are never in the autoclave.
Fenike, is there a contraindication? Is there a time when you would say this, I would not use this technique? Obviously, like an infected wound, etc.
Yeah, but that's really the only. So if you have an infected wound with a lot of hypergranulation and a lot of slough going on, then I would, and obviously then you would not mesh graft it either, because you would lose your graft. So always, as with every procedure that's not new to the room, do proper wound bed preparation, but then there is no contraindication for the Meek technique. Even a lot of studies came out, and they feel that Meek micrografting, because they are standalone little grafts, they tend to do better in colonized wound bed, because each graft that has a good graft take does not influence. So if there is an area in your wound where there is trouble, it does not influence what happens on the other side of the wound bed, because they're all standalone grafts. Whereas the mesh graft is like a highway for problems. It's like little tunnels through which problem can run.
Yeah.
So I know of a lot of doctors that we actually use Meek over mesh when the wound is kind of because of the standalone grafts. But there is no contraindication. I would say it's the same indications for mesh grafts. Yeah.
Very good. Well, thank you so much for this overview.
Not a problem at all.
And I think it would be very interesting to see how we progress and how our experience grows, because
Sure.
it sounds like there are many small steps and
There are
possible mistakes one can make, and I'm happy that people from the Dutch burn unit from Beverwijk as well as Rotterdam,
yes,
the burn team in Kampala, and maybe they can get some experience to show and help colleagues all over Africa. So
because Dr. Annabeth de Vries as well as Dr. Kees van der Vlies are working with you, right?
Yes.
Yeah, these two are very experienced in the Meek technique. I know them both. So they will be happy to help you with everything that you need to learn. But like when you have done something or you need more questions answered and you feel like you can reach nobody, I'm always happy there to assist.
All right.
Just the last one, as you wind up, any comment on aesthetics? The outcome when we do a thin split skin graft, we have cobblestone sort of appearance. Any comparative studies?
Yeah, there has been actually a study done in Egypt that has compared Meek and Meek 1-3 with Meek Mesh 1-3 to Meek 1-3. It's been done by Dr. Narwhal, I think. Well, it's in Egypt, a study from Egypt, and it's been a prospective trial in which they found that Meek performed in that study better than the mesh graft technique, but this is a Meek 1-3. And there's also been a work done in some Asian country, I kind of forgot. And that is, they compared Meek over mesh, but in a cohort study. And in those, also the Meek came out better as well in functional, as well as in social answers. But I know there is more studies that need to be done to have more on finance as well as on patient opinion. So more work would be nice to have more work done in that field, but we all know that burns is not a field that a lot of companies want to put a lot of money in because it's such a small niche.
Mm-hmm.
Can you put your email on the chat? It's on top of the chat. If you scroll to the top of your chat box, my email is right there. There was another question coming in the chat box. That's why I think you... do you see it, Mr. or Mrs. Senibi?
f.tempelman@umeka.com.
Yes.
Otherwise, if it's okay, I will put it in our app group as well.
No problem at all. Please go ahead, do so. Well, thank you all for joining us. I really enjoyed being here today.
Thank you so much, and I wish everybody a great evening. Thank you for joining.
Bye-bye.
Thank you so much. Bye-bye.
Thank you. Thank you.